All right, good morning, everyone. I'm very pleased to introduce my team, Anoushka, Arthur, Surabhi, and I am Lindsey. Our purpose today is to provide clarity on BC's stance towards a national plan for long-term care, outline BC's conditions for engagement in such a plan, and provide draft solutions for what a national long-term care strategy might look like in Canada. Taking a look at our agenda, our presentation will cover the problem, background, BC's conditions, policy options, implementation, and feasibility. The problem we are faced with today is that Canada needs a comprehensive national strategy in long-term care that can address COVID-19 in the short run and achieve high standards of care in the long run. In March 2020, BC's first COVID-19 outbreak occurred in a long-term care facility. Following this, there was swift policy action to address LTC COVID-19 outbreaks. Key initial policies included a visitor restriction policy, PPE allocation framework, single site order, and labor adjustments. These policies ensured that only consistent essential personnel entered LTC facilities, thus minimizing the risk of exposing vulnerable residents to COVID-19, outlined a strategy for PPE supply and usage to protect workers, and mandated that all LTC workers were entitled to full-time hours and pay at union rates regardless of prior contract status. Subsequent policies that have been particularly impactful are the federal government's COVID-19 Resilience Stream funding package, which has created room for infrastructural upgrades to promote distancing practices, and the BC government's Fall Preparedness Plan, which dedicated $44 million to hiring new healthcare workers to fill unmet staffing needs. Key insights from BC's long-term care COVID response are that overall, governance and policy actions were very strong. Decision-making was rapid, centralized, transparent, and coordinated. While operations and workforce responses eventually adjusted, this is where we saw the most gaps. In other words, implementing public health orders was not always consistent from facility to facility. This disconnect was most pronounced in BC's private long-term care facilities. And this is a problem because BC relies heavily on the private sector for long-term delivery. Of our 293 long-term care homes, 62% are privately operated. Stratified by funding model, that's 28% private nonprofit and 34% private for-profit. The reality is that 2/3 of BC seniors in long-term care reside in a private facility. Because of the disconnect between public governance and private service provision, private for-profit facilities fared the worst through the COVID-19 pandemic. These facilities saw more outbreaks, and those outbreaks resulted in more cases and more deaths. Approximately half of all outbreaks, half of outbreaks with over 40% infection rate, and half of outbreaks with over 10% fatality rate occurred in a private for-profit facility. This is not acceptable. British Columbians living in these facilities are suffering. This is why we need a policy response that addresses standards of care in public and private LTC facilities. Areas to focus on include BC's failing LTC infrastructure and low staffing levels. These issues are ongoing and predate the COVID-19 pandemic. With regards to infrastructure, 117 LTC facilities require renovation, and 20 facilities need to be replaced entirely in the short term. With regards to staffing, only 13% of BC's facilities meet minimum staff to patient ratios outlined by the BC Care Providers Association. The COVID-19 pandemic was a wake-up call to a much larger issue in Canadian long-term care. We need a sustainable strategy that can address underlying problems and manage Canada's fast-growing senior population, because by 2047, 1 in 4 Canadians will be over the age of 65. BC recognizes the need for a national strategy in long-term care. Looking internally, this strategy must facilitate higher standards for infrastructure and staffing, but must recognize that for BC, as with other provinces, the private sector is a major player. A national strategy must allow for flexibility in mode of LTC delivery. Looking externally, we would like to see a centralized funding model delivered through the federal government. Meanwhile, provinces should take the lead in implementing specific standards, as that is where the technical and context-based expertise in long-term care service delivery lies. I will now pass it over to my colleague Anoushka, who will outline draft solutions for what a national LTC strategy could look like.
Thank you, Lindsey. Let us now look at the policy options to improve long-term care in Canada, which are an extension of the Canada Health Transfer, the funding of long-term care through GST revenues, and finally, the Canada Long-Term Care Insurance Program. The Canada Health Transfer is essentially an existing mechanism through which the federal government can inject funds to meet the immediate challenges that we face today, through an establishment of minimum standards of care, as well as the possibility of targeting different sectors for improvement. This policy option can be used to improve and rebuild the current system. Since the administrative structure is already in place, this option can be used effectively for short-term responses. Moreover, the Canada Health Transfer already has the approval and support of both the provincial and federal governments. However, this option has an unsustainable funding model since it relies on huge fiscal spending from the federal government. Additionally, since the Canada Health Transfer does not specifically address long-term care, the standards established cannot directly address the challenges faced in long-term care facilities. To summarize, this policy option addresses staffing and infrastructure requirements through an injection of funds and the establishment of minimum standards of care. It allows for provincial flexibility, but does not remedy the problems faced by seniors in long-term care homes. Our next policy option is to fund long-term care with GST revenues. This model would involve the transfer of lump sums to provinces based on specific agreements with them. Funded through an increase in GST, it focuses on providing a continuum of care to all beneficiaries. The strength of this policy option is that it offers provinces the chance to direct funds as per their requirements in specific sectors. However, this model is financially unsustainable since it requires an increase in federal taxes. It can also be difficult to establish federal standards of care through this approach. Finally, since this model adopts an income-based approach, it can provide very basic services to all its recipients. Thus, this policy option cannot directly address staffing and infrastructure challenges because it cannot establish federal standards of care and a sustainable funding model. It does allow for a high level of provincial autonomy in its implementation of services. Our third policy option is the Canada Long-Term Care Insurance Model, which is a mandatory public insurance specifically designed for long-term care. Focusing on the quality of care, it relies on a needs-based allocation of services, providing all beneficiaries with a continuum of care. Its strengths lie in the fact that this reduces the institutional burden on long-term care facilities and allows resources to be allocated towards a better quantity and quality of services. Its sustainability relies on two components: a funding model similar to the Canada Pension Plan and the establishment of federal standards of care after provincial consultation. However, this model does not adequately address the short-term needs of Canadian long-term homes and requires the establishment of an entirely new administrative framework. To sum up, this policy option improves staffing conditions through the establishment of standards of care, reduces infrastructural burdens, and allows for provincial flexibility in implementation. Let's briefly review our policy options and outline our recommended course of action. The Canada Health Transfer and the funding of long-term care facilities through GST addresses some of our internal and external conditions, but does not provide a holistic, sustainable solution to Canada's long-term care crisis. Our third policy option, however, provides us the opportunity to directly address the challenges faced by seniors in British Columbia as well as Canada, while simultaneously improving the quality of care provided to them. Thus, we recommend that the Canada Long-Term Care Insurance Model be applied across the country. My colleague Surabhi will now take us through the details of the implementation strategy.
Thank you, Anoushka. I will now discuss the implementation of our recommended option, CLTCI. Some of the key features of CLTCI are Canadians above the age of 40 will be covered under CLTCI, but will only be eligible for in-home or institutional care in case of severe disabilities like dementia. Otherwise, beneficiaries will have to be 65 years or more to be eligible for care under CLTCI. All Canadians will be required to pay the premium from the age of 18. We recommend that premiums begin at a baseline of 5.5% of monthly income. The premium contribution shall be split between the employee and employer equally. At-home or institutional level care to eligible beneficiaries will be administered post a needs-based assessment is completed at community or municipal level centers. As provinces shall implement CLTCI along with federal government, provinces should have the liberty to decide if additional subsidies are needed to be given. We recommend that CLTCI be implemented in 3 phases. Phase 1 will last from 2021 to 2023 and will focus on administrative setup of the CLTCI. Phase 2 will begin from 2023 until 2047. It will seek to establish the cost structure of CLTCI and finalize the service delivery mechanism. Phase 3 will seek to ensure the long-term self-sustainability of CLTCI. Under Phase 1, CLTCI Investment Board will be incorporated as a Crown Corporation and will have a similar mandate to Canada Pension Plan Investment Board. The federal government will also have the opportunity to further deliberate on how to set up the CLTC Investment Board. Provincial governments will use funds from COVID-19 resilience infrastructure stream to repair, retrofit, or upgrade existing long-term facilities or build new community or municipal level infrastructure that will be needed under CLTCI. Phase 2 will see the institution of federal and provincial level task force that will meet every 5 years to establish a standard of care that will be provided under CLTCI. Long-term facilities that only meet the standard of care will obtain LTCI funding. Municipal and community level centers will be staffed, so needs-based assessments of seniors can begin to determine if they need at-home or institutional care. Provincial government will establish and monitor the assessment process along with the licensing of the workers that provide care. We anticipate that at-home care component of CLTCI will help in decongesting long-term facilities so that waiting time for seniors that require acute level care is reduced. Finally, eligible Canadians will also have the option to use up to 2% of their Canada Pension Plan contribution for CLTCI, but that will be available only till the year 2047. Next slide, please. Under Phase 3 consultations, federal and provincial ministries of health will continue to ensure that care funded under CLTCI remains financially sustainable. Further consultations would help to decide how standard of care will change and adapt depending on the change in demography. As we're looking at a period after 2047, the federal government may have to increase the baseline premium of 5.5% to ensure affordability of the CLTCI program. Lastly, provincial governments will have the autonomy to decide if they want to provide additional subsidies for LTC to reduce the cost of care for seniors. The provinces can also explore options to allow co-payments or exclude services that will not be provided under CLTCI for their own jurisdiction. I will now pass the discussion over to my colleague Arthur to discuss feasibility of a recommended option CLTCI.
Thank you, Surabhi, for discussions on implementation. So I'd just like to focus on a little bit about feasibility for our plan. So recall that the mechanism that will be driving improvements in long-term care is done here by 2 things. First, it's ensuring that under the long-term care insurance model, the government will anticipate that people save in anticipation of their potential long-term care needs. So, it might not be desirable now, considering that the percentage of the population above 65 is around 19%. But by 2047, projections estimate the old population above 65 to be around 25 to 27%. So that's 1 in 4 Canadians. So that 2.75% that you see there is the estimated premium for what we anticipate will be at the start. And so this is calculated based on the annual transfers that is currently published under the Canada Pension Plan, and taking a fraction of the transfers to estimate the amount of transfers projected for long-term care insurance. The second mechanism is that when we shift our funding for long-term care insurance under this model, we essentially free the need for tax revenues to contribute in subsidizing existing LTC costs. So that 1.3 billion that you see there is what the current BC government spends on subsidizing long-term care. And this would essentially be shifted under the LTC model instead. This allows provincial governments to really decide what they want to do. So if they want to reduce taxes, that's certainly one option. But if they also want to use up that freed up money to invest in long-term care infrastructure, now that would also be an option. But also keeping in mind that under our LTCI model, funding of service would also be tied to assessments established and standards established in terms of eligibility by consultations from the federal and provincial levels as well. And so as a result, this would create an incentive for provincial governments to ensure that the freed up revenues that they're generating are used to create conditions where medical care and attention is properly invested in for high quality service. So in brief, this slide basically captures how the LTCI model would create conditions where we can redress more of the long-term problems. So currently the burden to subsidize long-term care by using tax revenues is not sustainable insofar as the underlying principle should be that people should be saving more for themselves. And so when we alleviate these burdens, governments can then decide whether they want to keep the same level of taxation or if they want to lower them. But other options exist. For example, they can reduce tax levels to a point where we can alleviate some of the burdens on individual household income earners, but also maintain tax levels to a point where budgets can allow for expenditure on investments. And these investments can include more training and staffing opportunities, more investments in long-term care retrofitting and infrastructure, as well as existing investments in terms of building COVID-19 and pandemic response capacity. So lastly, here's just a couple of risks that we've identified and some mitigation strategies to focus on what we can anticipate. So the first risk that we assessed is the possibility of provincial and federal government coordination breaking down. And so in turn, this can either involve negotiations in terms of the standards of care are not conducted thoroughly, or the possibility of provincial support just not being in existence under this model. And from a budget perspective, this does alleviate an area that provinces have to cover in terms of their expenditure. So there are some certain benefits in terms of adopting an LTCI model. Even regarding establishing standards of care, the eligibility requirements placed on facilities is really negotiated between province to province. So you can think of it really as the federal framework in terms of funding allocation, but the provincial framework in terms of how that funding is effectively allocated. So the second concern is the fear of double burdening or double subsidization that may be a source of concern from the public. And so while there might be an underlying uncomfortable truth with all of this in the sense that long-term care spending will have to increase given that more Canadians as time progresses will be comprised from the older demographic. And so to that end, at the very least, we can provide and recommend certain mechanisms that ensures the system is relatively progressive, such as more incentives and tax credit for low income or no senior family dependents. And then finally, our main source of high risk is on the issue of finance sustainability. So this is the possibility of whether or not the long-term care insurance model can actually cover enough for provincial care. And so to this end, we recommend providing a mechanism where it does still allow provinces to decide whether they want to subsidize additional costs or allow the possibility of implementing co-payments, just in the event that the LTCI insurance does not completely cover the costs. And ultimately, on the other hand, we do recommend that there might be a mechanism that should be in place just to ensure a cap between 20 to 30% of the full cost of long-term care, just to ensure affordability. So ultimately, the recommendation for the Canadian long-term care insurance model would ensure that, at least in the long run, provinces can focus really on improving the service rather than really just covering the costs of patients right now. And so with that, I want to thank the panel for providing us the time to present our findings. And we look forward to engaging with you on questions pertaining to the matter of long-term care for Canada.
You're muted, Jim.
Sorry, I'm going to turn it over to Steve Orsini for questions. I'm sorry, forgive me.
Great. Thank you for that presentation. Very professional and thought-provoking. I'm sitting back thinking, okay, we're going to brief the Premier. What strategies would the Premier need to convince Ontario and Western provinces, east of BC, that have been traditionally opposed to what are seen as tax increases? How can you frame this option to win them over?
Sure. So I suppose I can address this, or I can propose some strategies to address this. So in essence, the idea of a long-term care insurance would be to really adjust the transfers of taxation. So right now, what's occurring is that for most provinces, how long-term care costs are covered is through general taxes at the province level that's being transferred back to subsidizing long-term care costs. So ultimately, in the long run, the long-term care insurance model would see basically an increase in premium rates that are being paid by income earners, proportional to the amount of tax decreases from the provincial level that is currently used to subsidize these long-term care costs. So it really, in a way, it's transferring the part of the provincial tax burden of subsidizing long-term care really onto a federal program that's almost similar, akin to a pension. But in the meantime, there's also another area where it provides a mechanism by which provinces can adjust the tax levels so that they can still have an opportunity to provide investments and funding for infrastructure projects. And so as a result, there will be kind of a gradual process. But then again, given a backdrop, when we look at, there was an Abacus poll data that was conducted last May, where it basically said that approximately 80% of Canadians still support the idea of funding, of increasing spending for long-term care investments. So ultimately designing that, at least for other provinces in this perspective, is really just to convey the message that this is a transfer of burden of cost to the federal government so that it frees up the room for provinces to invest in their long-term care.
Arthur, thank you. I'm going to turn it to other people so they get a question in. Start with Janine, Richaud, and then Andre Fortier.
Thank you, and thank you to the group for the presentation. There's a lot of good information in here, but what I haven't seen is communication strategy, and there's an awful lot of stakeholders who will have a variety of points of view with respect to the policy recommendation that you're putting forward. I'm thinking employers who would have to contribute to the plan, taxpayers who or employees who would also be contributing as well. And I wonder what you've thought through from the communication perspective and how you would sell this to the various groups of stakeholders that will have a lot to say about this.
I'm happy to start off on this question. So with regards to framing this policy for the public, I think it's important to frame it not as a tax increase, but it's an insurance. They're paying in to fund their own care. So the value that they're putting in, they're going to get out at the end of the day in terms of the quality of care that they will receive as a senior. So that would be the primary communication strategy for the public. With regards to the employers, yes, they are a key stakeholder in this program, as we are proposing that there's a split contribution between employer and employee. From here, with this, we can pull from examples, for example, Canadian climate taxes, where there's an increase in tax in one area, but perhaps in another area, there can be a cutback or a shift in taxation to uplift that benefit for them. And then at the end of the day, it's building up that understanding for employers that, again, as individuals, they're receiving value from this program as well. Everyone's contributing and the value back to everyone will be lifted up.
Thank you very much. Let's go to Andre Fortier, and I'd ask the panelists or the team members to keep your answers as concise as possible. So Andre, over to you.
Yes, thank you for the presentation. I have just a precision, I think. You're proposing to transfer the revenue issues, but I don't see the net improvement or the net additional resources to improve the actual services. So how could we have the federal government and even other provinces and other stakeholders buy into your proposal?
So,
Who wants to take that? Go ahead.
yeah, so in terms of infrastructure, there's the COVID Resiliency Fund plan, which is already looking into changes that the provinces can make in their existing infrastructure or build an infrastructure under CLTCI. The federal government, when they introduced the COVID-19 Resilience Fund plan, already stated that health infrastructure applications can be made under that. And we are suggesting that we pivot on that fund to improve the existing infrastructure. And in terms of standard of care, there will be a federal and provincial task team that will look into establishing a common standard of care across Canada to help with improving care.
Okay, thank you. Let's go to now to Ronelle Wilson.
Okay.
Sorry, Anoushka, were you going to say something? Go ahead. Or somebody was going to say something.
Oh, no, I was going to add on to the question. I was going to add on to it, but it's okay. We can move on.
Okay, let's move to Ronelle. Go ahead, Ronelle.
Yeah, just, you know, I note in the solution, it's based on monthly income. So I'm just wondering about that discussion we have with our PT colleagues with respect to provinces where monthly incomes might be higher in some provinces. So will they expect to see a higher amount then transferred back to them? I'm just wondering how we will balance out, you know, our colleagues from Ontario versus perhaps our Atlantic colleagues with respect to sort of perhaps the equalization of those transfer payments back. Maybe you could just clarify that for me.
Sure. Yeah. So,
Arthur, do you want to?
or if you want to go ahead, then yeah, go ahead.
It's okay.
Oh,
it's okay.
Okay. Sure. So yeah, the funding mechanism would be tied on the proportion of the facilities and the proportion of the demand that's between provinces. So I think historically there's always been a problem of equalization across provinces, at least from the federal level. So I think the main emphasis really is on the quality of care first. So it basically, the funding distribution, so obviously, people that are earning higher income will be paying more, in the sense that it's designed to be progressive in such a way. But the transfer of costs really is dependent on the facilities across the province, so that way the facilities are actually funded, and that's the important priority.
Okay, other comments or questions? I've got one. Sorry, Susie, you go ahead. Sorry, Susie McDonald.
Thank you. I'm just interested in exploring this CPP buffer to just make sure I've understood. So is the idea that you could use your CPP contribution towards this long-term insurance as opposed to keeping it in the CPP? And in that instance, are we not just taking money that's probably being used for long-term care or other pieces or care at home and moving it into this instead? Like I don't see what the benefit is there.
So what we're proposing is that only till the year 2047, we allow some of the beneficiaries to use certain part of their contribution from CPP. And that's an optional that the beneficiaries can decide. Why we suggest that is that they could use already what they've contributed to CPP or what they wish to contribute to CPP to earmark for their long-term care. And that's an optional feature on their program so that the LTCI funding is not underfunded by any chance.
Colleagues, let me ask one question, if I may, just because we've got a minute left. Can you explain to us, is this an individual insurance program for income earners to basically build up an insurance account that they can draw down when they get old? Or is it a way of funding provincial spending on long-term care in its broadest sense?
It's, I would say that it's a broad initiative because everyone is pooling in the resources and then whoever needs can benefit from them. So as we move on, sorry.
So I benefit in that the province provides long-term care to me. I don't benefit in that I get to choose that I want to use this home or that one, or that I want to have a certain standard of care, or that I whatever. Or if I haven't contributed, I don't get the care. So does everybody get the care, for example?
So to answer your question, first, everyone does get the care involved. And then secondly, because we're establishing federal standards of care, so we're supposing that everyone can meet certain standards, and we're waiting till 2047 to start implementing it so we can make sure that everyone meets those standards of care. Also, we're using a needs-based allocation approach, which means that you will be provided the care that you need. In case you only require in-home services, there will be someone who will be helping you out at home. But in case you need an institution, then you will be provided to your nearest institution. And those are the nitty-gritties that we're allowing provinces to sort of get down and decide based on what their requirements are.